Okay. Good evening, everyone. Welcome for the webinar session. On behalf of Opta EC, I welcome you all to the 16th Interactive Opta webinar series on oncology rehabilitation. Myself, Arvindin, the General Secretary of Opta. I belong to batch of 2013, and I will be moderating today's session. It's my privilege to introduce our today's speaker, Mrs. Blossom Pratheesh ma'am. So ma'am belongs to batch of 2009 OT, who is a certified lymphedema therapist under the Academy of Lymphatic Studies, USA, with advanced training in head and neck lymphedema management. Now ma'am is currently working as an occupational therapist with Advanced Center for Treatment, Research and Education in Cancer under the Tata Memorial Centre in Kharghar, Navi Mumbai. I welcome ma'am for this interaction session, for this interactive session. I would like to hand over this this session to ma'am now.
Yeah, thank you so much, Arvind, and thank you, Opta Managing Committee, for giving me this opportunity. Yeah, so without much delay, I would move on into the presentation for today. So I'm planning to talk on different aspects of oncology rehabilitation. Now, this is just what I'm planning to is an overview presentation. I'm planning to highlight on what are the areas that could be worked. And at the end of the presentation, a bit of the challenges that I have faced while trying to, in the process of establishing services here. Yeah, so moving on into the presentation. So cancer is one of the leading causes of deaths, and the 2020 reports by ICMR says that there's a sharp increase of cancer cases in India, and there is a possibility of 12% increase in the next 5 years. Now, although the survival, the good thing is that survival has increased, that the 5-year survival rate has increased in cancer. The treatment options are much more advanced, and that is a positive aspect. But what oncology rehabilitation aims to do is to help the patients deal with the side effects of the treatment. So oncology rehabilitation is a scope that we, or is an area of scope that we as professionals can move into, because there is a chance of, like I said, there is a chance of high increase in the cancer incidence in the coming years, and definitely rehab will have a major role to play. And coming to India, oncology rehabilitation, comparing to its how it is in the West, it's still in its emerging phases. And so there is much prospect for how we can develop the services and explore other areas of intervention. So this is just the of where I work. I work with ACTREC, which is under the Tata. So there are different levels in oncology rehabilitation. So we primarily work in these 4 areas. So one is preventive, restorative, supportive, and palliative. So these are the 4 main areas that we work with. And give me just a few seconds. Hold on, please. I need 2 minutes.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
I'm really sorry.
Ma'am,
for
no
that.
problem. Ma'am, the slides are not moving, ma'am.
Yeah.
To remind you.
It's not moving.
That's not moving. You can scroll down.
Coming to the levels of oncology rehabilitation. So these are the levels that we work in. So we work on a preventive note, which means we educate the patients. We can educate the patients on how we can prevent cancer as a lifestyle condition. Restorative, which means about the deficits that they have. What are the restorative, for example, on strengthening and different aspects of restoring the limitations that they have. We can work on that note. We can work on a supportive level. We can work in a palliative note. So in our setting, the different DMGs that we deal with are gynecology, urology, breast, neuro, head and neck, bone and soft tissue, pediatric hematology, adult hematology, and to this we now have a palliative unit also. So what I'm going to do in the coming slides is about each of these DMGs, just a brief on what are the areas that we work as rehab professionals. So in the breast, now DMG means disease modifying group. So this is the breast DMG. Now, how do we work with the breast cancer patients? So immediately after the surgery, now, like I said, we in rehabilitation, we deal with the different aspects of the side effects of treatment. So after the surgery, post-surgery, our physiotherapy professionals, the next day after the surgery, they have a post-operative breast class where they educate the patients on the basic exercises that they could do right from day one post-surgery, which would help to improve the shoulder range of motion, as well as they educate on some preventive aspects. Now in breast cancer, we all know that there is they remove the lymph nodes in most of the cases. So when the cancer has spread to the axillary lymph nodes, they remove a couple of nodes depending on which of them are affected. So now, once the lymph nodes are removed, there is a chance of developing lymphedema because the lymphatic fluid will not be effectively drained as much as it was before. So they educate the patients on what precautions they could do to avoid to avoid lymphedema, to manage lymphedema. So that happens on day one post-surgery. Then what the other aspects of rehab are, we give the breast prosthesis, the lymphedema management. Now, if there's an occurrence, we help the patient manage it, and the follow-up of patients. Now, this is a picture of lymphedema. So like I said, lymphedema, we all know that in addition to the blood, there is the lymphatic fluid which flows in our body. Now, what happens in lymphedema is the system is not competent enough to drain the fluid back, which means that the lymph gets collected in the extremity. Now, this happens in the extremity. In cancer patients, it happens in the extremity where the node is removed. For example, the axillary node is removed in the right side, the right limb will be affected. All the other parts of the body, the lymphatic system remains intact enough to drain the lymph fluid. So once the fluid collects, now this fluid the protein accumulates, and protein is hydrophilic. So what the combination of fluid that accumulates in the extremity is protein and water. Now, more the protein, greater chances, more the deposition of protein, greater chances of, which means more the fluid collects, the greater chances of fibrosis. Over time, there are stages of lymphedema that the patient goes through if it is not managed effectively. And I believe a detailed session on this was taken by Anita Rebecca ma'am few months back. So I'm not going into much detail, but this is just an overview of lymphedema management. Now, the lymphatic system definitely weakens over time. So in a course of 5 to 10 years, there will be increased chances of lymphedema, of the patient developing lymphedema. So there is a mechanical insufficiency because in the lymphatic system, because the nodes are removed. And as the years progress, the risk of developing lymphedema increases, which calls for the need of professionals who are trained in lymphedema management. Now in India, this is very less, but the India Lymphedema Foundation is doing a great job in training, in organizing programs, CLT programs, so that professionals like us, OTPT, and even physicians can attend, and we can be trained in lymphedema management. Now, why I said this is lymphedema is one area that is budding. I mean, all of us, we can think of, getting ourselves trained in lymphedema, and it is good in terms of the remuneration also. So what in lymphedema management, what all we can look at, what evaluation we do is we measure the lymph volume. We look at what stage the lymphedema is in, and there are two phases in lymphedema management. So the one is the intensive phase and the other is the maintenance phase. So in intensive phase, we primarily teach them skincare precautions, the exercises, decongestive exercises. So we teach them the bandaging techniques. So these are the different aspects that come in intensive management. So it's the therapist who does the MLD, that is the manual lymphatic drainage, followed by the compression bandaging. So this happens in the intensive management phase, which can go up to 3 or 4 weeks till the patient's limb volume plateaus. And then in the maintenance phase, we educate the patient on doing a self-manual lymphatic drainage and the self-bandaging technique or the compression garments on how to use them and maintain this. So now lymphedema is one problem which cannot be rectified completely. So once the lymphatic system weakens, there is no chance that it would recover completely. But we can educate the patient on how to maintain it, maintain, increase, or further prevent increase in the limb volume. And like I said, this involves manual lymphatic drainage. I'll explain more about it. Compression bandaging, decongestive exercises, patient education, and skincare precautions. Now, these 5 headings that I've mentioned at the end is together called the complete decongestive therapy. So this is just a diagram of the lymphatic system. And so in breast cancer, what happens is they remove the axillary nodes on the affected side. So we use the other nodes that are healthy, and we use those areas to drain the fluid. We do the MLD to drain the fluid into the normal lymphatic nodes. So this is just a picture of MLD. Now it's a very gentle technique where they stimulate the superficial layer of the skin. It is not a deep technique. It's just a superficial, gentle technique where just the superficial lymphatic layer is stimulated, so that we do a movement technique. There are different finger techniques that we use to help the fluid, to increase the speed of the fluid, of the lymph fluid that is being drained. What are the benefits of manual lymphatic drainage? So it increases the speed, lymphangiomotricity, which means the speed with which the lymph fluid flows through the lymphatic system, and which the speed in which the lymphatic system, there are valves, which the speed with which it is able to push the fluid back. It increases the venous return. Now, because we are pushing all the fluid into the healthy areas of the body, the venous return increases. It helps in rerouting of the fluid. So we are changing the direction. The fluid that is accumulated in the affected limb, we reroute it to the other healthy areas of the body. It has an analgesic effect. So this can be used in palliative care also. MLD has an analgesic effect, which gives a soothing effect for the patient. Creates a suction effect on the distal collectors. Now, it's like a traffic jam where in order to control a traffic jam, what we do is we evacuate one area. We try to move the vehicles that are there in one area, and then the vehicles behind it actually are able to move forward. The same kind of system is that we follow in MLD as well. So we evacuate the proximal areas. We make sure that the proximal areas are cleared out first. We drain it to the healthy lymph nodes, and then we work on the distal areas. So when the proximal areas are cleared out, there is a suction effect which pulls the fluid from the distal area. So this is what I meant by this point. It creates a suction effect on the distal collectors. And it helps in fibrinolysis. Like I said, lymphedema, the fluid that is collected is a combination of protein and water. So when this happens over time, when there is more accumulation of protein, there can be fibrosis which happens. So MLD has techniques which help to break the fibrosis. And definitely this helps to soften that area and develop the condition of the limb. There are different indications and contraindications of MLD. And this is how we do the compression bandaging. So after the MLD, so that means we're pushing the fluid to the other healthy areas. And then we use the compression bandaging to maintain that effect, whatever fluid we have pushed into the healthy areas, so that it doesn't come back to the limb. We use the compression bandaging to maintain the effect. So this is the whole idea of complete decongestive therapy, and we should do the exercises together with the compression so that the fluid is effectively pushed back into the other healthy areas. So like we can see that the bandages are put right from the fingers till the proximal end as much as we can. Like I said, the lymphedema certification can be taken from, there are different organizations that give the certification. So one is CLOSE. I have taken it from ACOLS USA, and there is a foundation in India. It's called the India Lymphedema Foundation. I've given the two websites below, ilf.awareness@gmail.com, and Jaideep Patak is the one who is organizing. I mean, he is the director of the India Lymphedema Foundation. So he can be contacted directly, and he can mail you or he can inform you of the dates. He's usually yearly once they conduct training programs in India, and the basic CLT course is 9 to 10 days, and the advanced course for head and neck, this was the first time. This year they did it for the first time in India, the advanced course. So they did a portion of it, which was just the head and neck lymphedema management. So when we contact them, they would keep us updated about when they're planning to organize these sessions, and we can apply accordingly so that we can get the certification done. Now, the certification is useful because it gives us a really professional way of looking at things. So there are trained people who are coming from the USA, from the Academy of Lymphatic Studies, who come here and they train us on with hands-on methods. So this is really useful if if we are interested in oncology rehabilitation, taking a certification in lymphedema management would be really useful. Now, this is how the breast, this is how once the fibrosis has set in, this is how it looks like. So this is like stage 3 lymphedema. Now it has, there is collection of fluid in the trunk also. So this is the breast portion of the patient, which is this way in appearance. Now, how this can be managed is definitely with MLD. And during the bandaging, we put certain pads in the areas where there is fibrosis, where we feel that there is fibrosis. So these pads, they could be chip bags, they could be pads, they could be different other dense or foam materials that we can place in these areas of fibrosis, which helps to break down these areas. So that is one thing that we do when we bandage. This is the prosthesis. So in our setting, we're using the triangular, which is shown on the left side of this screen, triangular kind of prosthesis. So once the patient has undergone a complete removal of the breast, a mastectomy, so the weight of the body is not balanced effectively, and hence it requires that the patient uses a prosthesis in order to balance the weight on both sides. There are also different NGOs that develop cotton prosthesis, breast prosthesis, which this is actually around 5,000, which in Tata, they're giving it at a subsidized rate. This is like 5,000 in Tata, which means outside it's more costly. But the cotton prosthesis that is being made by certain NGOs is also good enough. So that is also being given to patients who cannot afford this one. So this is the silicone prosthesis. Now coming to gynecology and urological management. So what we call it is the GUGI. So there also, when there is a removal of the lymph nodes, but the inguinal lymph nodes, there is a chance of lower limb lymphedema. And again, the skincare precautions and the lymphedema management, lower extremity lymphedema management comes into place. So what happens in gynecology, in cervical cancers especially, is once they receive the radiation therapy, so radiation is a kind of heat that they give to the particular area to destroy the cancer cells. So what happens is post-radiation therapy, there is a chance of vaginal stenosis, which means the vagina narrows down, the cervix narrows down. So there is the management. One of the areas of management that we can look into is to train the patient into managing vaginal stenosis. Sexual health concerns. Now, once they have cervical cancers, they have a fear of engaging in sexual activity. So educating the patient on sexual health concerns is also another area that we can look into. Vaginal lubricants, it's being practiced in the West. Sex toys, all these are being practiced in the West, but in our setting, this is yet to come. Kegel's exercise for incontinence. Scrotal edema is is another difficulty that the patient can develop. This again can be managed effectively with compression bandaging. So sometimes the patient will not be comfortable to share this with the therapist, but it might cause a huge discomfort for the patient, scrotal edema. So it is important to assess while we evaluate, to ask the patient if there are such difficulties, to ask questions related to this so that we can intervene with this also. Compression bandaging really helps with scrotal edema. These are vaginal dilators, like I mentioned in the previous slide. Vaginal stenosis, in case of vaginal stenosis, we educate all our patients to use vaginal dilators. Now, there is a kit that is available. Again, that is made by an NGO. And there are silicone dilators. 3 dilators. One is of the large size, the medium, and the small one. So the patient is educated on how to use these dilators to maintain the cervical space. So what they do is we educate. Once the patient completes the RT, they are sent to the occupational therapy unit or the physiotherapy unit, and they have to put the condoms on these dilators and wind it in their cervical area, wind it round in their cervical area so that they maintain the dilation, so that it doesn't close. And it might be a little painful, but they have to do this so that it doesn't come back, constrict itself. Oral cancer rehabilitation. The other DMG that we look at is head and neck cancers. And coming to GU, cervical cancers, HPV virus is one of the most important causative factor of cervical cancers, at least in India. And it is in the West. HPV is now also becoming a prominent cause of oral cancers because of oral sex. So in India, oral cancers is mainly can be mainly attributed to the use of tobacco. So what happens in head and neck cancers? Again, after the surgery, there is a course of chemotherapy, there is a course of radiotherapy that they undergo. Now, because of the radiation and because even after the surgery, they may have difficulties with jaw opening. So, and primarily with the radiation, with the heat being applied to the area of the temporomandibular joint, the radiation being applied there are chances of greater restriction in jaw movement, which is called as trismus. So the temporomandibular, the range of ROM of the joint becomes reduced. So there are ROM, particularly after the there can be shoulder and neck ROM restrictions. And again, with the nodes, the cervical lymph nodes being removed, there is a chance of lymphedema in head and neck. Fatigue management, ADL limitations are other areas that we can work on in oral cancer rehab aspects. Now, this is the head and neck lymphedema. So what happens is these are the measurements that we take in the patient. This might look complicated, but the ABC, the 3 lines that are shown in the neck area, are the neck composite measures. So we take it at the top portion of the neck, the middle portion, and the lowermost portion. So we take the measurements, circumferential measurement of the neck. And coming to both sides of the face, we take the numbers, the marked ones here from 1 to 7 are the composite facial measurements that are taken. So there is from the chin to the lower end of the jaw, from the tragus to the lower end of the lip, and the different measurements that are taken here are the composite facial measurements. Now, each side, all these measurements are added up on each side of the face, and it is compared. So the total is added. It's not that individual measurements are added, but the composite, the total of the measurements on each side is added up, and it can be compared on the subsequent sessions of intervention. Now, in head and neck lymphedema, definitely MLD is there, and we follow compression. MLD followed by compression garments is the line of management. But in head and neck lymphedema, gravity plays an important role, which means it is not as difficult to manage as in the case of upper extremity lymphedema. So definitely the patient needs to be trained, and it can cause a lot of difficulty. So when there is lymphedema, it can cause a lot of difficulty for the patient. For them, swallowing may be difficult. Speech would be difficult because there may be internal lymphedema, which needs to be corrected. And intervention, MLD together with compression bandaging gives promising results for the patient. So there are several studies in which once they undergo the management for lymphedema, there are instances where their NG is removed and a lot of other difficulties that they face are resolved. So head and neck lymphedema, if found out, can be one important area to intervene so that the patient's quality of life is improved on. This is again the different compression garments. Now in head and neck lymphedema, creativity of compression garments, of developing compression garments, any light, it's not that you need to have this much amount of compression, or there is no specific fixed amount of compression that we should be having in this kind of a head and neck lymphedema, but it should just be good enough to give adequate compression for the patient. So we can develop different, it depends on our creativity on what materials we can use to develop to make the compression garments. Some of them are available readily, but most of the time if they are not available, we can even create them. Now this, I'm not sure if this picture is clear, but this is how the patient, they have used a kind of tubular grip kind of material to give compressive effect to the face. Now, definitely the eyes of the face are not open because it couldn't be done at that time. But this is how it can be done. We can work on it with our own creativity. We can develop compression garments using our creativity. These are few other padding materials that are available. So we insert this below the bandaging. So these are different padding materials. There is Jovi pack. There are different materials that we can use as to give a padding effect for the face. We use this below the bandaging. This is now we know that kinesio taping is an adjunct to, it can be used together with the MLD and the bandaging for head and neck lymphedema. So this is how, just few pictures on how they have used taping for lymphedema management of the face. These are actually therapists. This was taken during our training class. So they are therapists who are posing for these photographs. This is a jaw stretching device. Now, trismus, like I said, trismus is post-radiotherapy and post-surgery trismus. Difficulty to open up the ROM of the TMJ joint is affected. So the jaw stretching exercise, what we do is we teach the patient to use this jaw stretching device. So this, they are taught to place it on the side of the mouth where the surgery wasn't done, the opposite side. And they have to open up the screw so that it opens just enough to give the stretch to the jaw opening. And they maintain it for the required amount of counts, and they have to do repeatedly. They have to repeat it through the course of the day. So this is a jaw stretching device that we give to our patients. This is the Terabyte. This is again for jaw stretching, but this is more costly. So in our setting, we use the cost-effective one. Now for patients, sometimes the jaw opening may be, so how we measure jaw opening is we measure it with the help of vernier caliper. Now, if that is not possible on a general note, we use the finger width to measure the jaw opening. We say 1 finger opening or 2 finger opening or 3 finger opening. 3 finger opening is ideal. That means 3 fingers placed vertically between the upper and the lower jaw. So now if that is not there, even if the mouth opening is not enough to insert the jaw stretching device, we advise them to use the wooden spatulas. So they have to join it together and insert it in the mouth so that the jaw is stretched enough to maintain the opening, and to slowly increase the number of spatulas so that the jaw opening increases slowly. So this is the mouth block. So after the jaw stretching, so they are advised to hold the stretch the jaw for like 10 seconds. Then after they have to repeat it 10 times and in an hour. And what they do is after they use the jaw stretching device, they have to use the silicone mouth block in their mouth between the upper and the lower jaw. They have to place it between the upper and the lower jaw so that the stretch that they have attained is maintained. So this block is placed inside the mouth so that the stretch is maintained. So this is the mouth block, silicone mouth block that we give our patients. Coming to bone and soft tissue cancers, supportive braces. So the Taylor's brace is one common brace that we give for pain management and as well as support of the spine. Prosthesis training in case of amputation. Now, depending on the site of the tumor and the amputation that is done, prosthesis training can be given. One of the common kind of the rotation plasty is one of the common kind of surgeries that they do here. So when there is a tumor in the femur, what they do is they remove that particular portion of the affected area. I mean, below the knee, they amputate the knee area is not affected. So they revert it, they reverse it. I'm sorry, I couldn't put a picture, but they reverse it to the opposite side and they attach it to the hip joint. So that is rotation plasty, and training the patient with rotation plasty is one of the areas of prosthesis training that we can do. Ambulation training on, especially in case of bone metastasis, how they can minimally weight bear and ambulate, and addressing other functional limitations. So bone and soft tissue cancers is another area. And we have probably in CMC in our setting also, we would have come across patients. So the line of management is what we have learned, but I was just trying to point out that this is an area that we can work on. Neurological tumors, again, depending on the site of the tumor in the brain or in the spinal cord, we know that there will be areas of deficit. So we can figure out those areas and work accordingly. Now, pre-rehabilitation is not specifically to neurological tumors. Pre-rehab can apply to all other DMGs as well. Pre-rehab is on educating, on evaluating the patient prior to the surgery on what all are their abilities, their range of motion, their strength, and other aspects can be evaluated prior to the surgery. And they can be educated on the effects of the treatment and the side effects that they are likely to face. Now, this makes them mentally more prepared to face the course of journey that is ahead. So pre-rehab is an area, it is widely advocated that pre-rehab should be given to every patient, but sometimes in our setting at least, it's not been able to practice it or implement it. They do audit on a minor note, the consultants educate the patient, but on an elaborate note, if it is done, it really helps the patient. So pre-rehab is also one area of research that we can look into. Again, with regard to neurological tumors, evaluate the sensory motor deficits, the cognitive deficits, especially in case of brain tumors. Developmental facilitation. So in pediatric cases, especially the children from 0 to 5 years, we can look at the milestones, that developmental milestones that are affected, not only the gross and fine, but the cognitive milestones, the other visual perceptual deficits, the other deficits, all the other deficits that they have, functional, other writing, different aspects of development that are affected, and help with them. Now, in the stem cell transplant, so in stem cell transplant, there are different kinds of, what they do is they transplant the bone marrow of the patient. So in stem cell transplant, there is autologous, there is allologous. So allologous is, there are more chances of the patient developing adverse effects because the stem cell is borrowed from another related person or from an outside person who matches the marrow of the bone marrow of the patient. So what happens is there is more chance of graft versus host disease, that is the GVHD that I have put in. So once the bone marrow transplantation takes place, they're in the unit for like 15 days, and then they're shifted to the wards, and For some of the cases, there is intense GVHD. Now, GVHD can be most occurring in the first 1 year. So some of the patients, like I recently had 2 children who were in the hospital post their transplant for like close to 1.5 years, 1 year to 1.5 years. They were hospitalized. They were on the hospital bed. So in such cases, it is important to look. One was a 3.5-year-old child and the other was a 7-year-old boy. So they did not have skin GVHD. What they had was lung GVHD and intestinal GVHD. So the functional aspects were good, but because they were hospitalized and because they were children, there were a lot more other areas that we as therapists could look into: their recreation, the developmental aspects, their cognitive aspects, on what all are they gaining. So most of the time, the children are, there is a tendency that they stick on to their smartphones. They're on bed watching their smartphones always. Now, the impact of smartphone is definitely, it still has to be researched, but there is a lot of functional limitation that they have, of activity limitation that they have, of restriction, participation restriction. So these are the areas that we can look into, some of the areas that we can look into when we manage children post stem cell transplant. And especially children, like I said, again, 1 to 5 years, we can look at the developmental aspects that needs to be, that were hampered because of the treatment. Now, this is one child whom I used a certain kind of activity, recreational activity. So she was quite, I could say she had a lot of anger outbursts, because she had one episode. Now with stem cell transplant, what happens is the course may be a roller coaster ride. They will have infections. They'll have to be hospitalized again. Now, most of us don't like, definitely they're so tired of the hospitalizations that they say, I don't want to be hospitalized again. So this was just an activity that I used to help her cope up with the pressure of being hospitalized or undergoing the treatment. So this was just breaking the eggshells. She was told that she's a soldier and she has to fight it bravely. So this was just something that I used. And this is again a recreational activity that I use for so this is post chemo. This was not after the stem cell transplant, but post chemo, he had an infection. Now there is a risk of infection where they are admitted. Sometimes there is a chance where they're admitted for like 3 or 4 weeks, depending upon how the infection subsides. So at that time, this recreational activity was used. And he was a child who felt very difficult to cope up with the hospital admission. There was no smile on his face. He wasn't talking to the nurses. He wasn't talking to anybody. And he also had family conflicts where his mother had passed away, and it was his second mother who was with him. So it was a difficult situation that he was going through, and he wasn't willing to. He missed his family. He missed his sisters who were back at home. So, and he wasn't very expressive about it also. So he remained silent. So this was one activity that I used, and he liked painting and crafts. So I used that to work on his leisure and recreation. Now, these are some of the areas. Now, it's been just 1.5 years since I've joined ACTREC, and what I presented, now I'm not really, I am still learning things on rehabilitation. I am still on the process of developing myself. What I just mentioned before this slide were areas that are already being practiced in our setting. And the upcoming slides that I'm going to show are areas that I have figured out, or I feel that these could be potential areas that we could work on. One is fatigue management. Now, I think I'm close to 7 o'clock, so I will just move quickly through the slides. Fatigue can impact fatigue. Cancer-related fatigue is one side effect of the chemo intervention that the patient undergoes. So this is not just the normal fatigue or tiredness that we feel, but it impacts their work, it impacts their ADL, it impacts their leisure and their quality of life. Now, this is not, the patient may not realize that he is in a state of fatigue. He may just feel like he's getting tired too often. So fatigue is one area we can intervene and educate the patient on how to manage. Again, pre-rehabilitation, education about cancer-related fatigue, energy conservation measures, sleep hygiene, CBT techniques, exercise, and physical activity. Now, physical activity is popular in the West, but in India, physical activity still needs to be emphasized as a treatment prospect for the cancer patients. Physical activity is very good, in fact. So it sometimes, I've heard people say that it has a magic effect. So encouraging physical activity in the patients, having a routine, setting a routine for physical activity could be very beneficial for the patient. Pain management. Now, pain could be due to different aspects. It can be related to neuropathy. It can be radiation therapy induced. It can be because the nerves are affected. There is plexopathy. It can be because there is tissue fibrosis or bony metastasis and pathological fracture. So we can evaluate pain using the visual analog scale. And there are different areas that we can intervene with role facilitation. Again, cognitive impairments, address their social isolation, modifications, exercise, energy conservation measures, CBT techniques are all techniques that we can manage with pain. Now, again, I would say that these are not areas that I've explored. I'm still yet to explore. So I've just put these titles from resources that I have gone through. Chemotherapy-induced cognitive impairments. Now, these cognitive impairments, unless they are related to a neurological tumor, cognitive impairments can also be an effect of chemotherapy in the other incidences of cancer. That means non-neurological cancers also. But this cognitive impairments can be very subtle. Usually they term it like chemo fog or a chemo brain. It can be very subtle, where the patient seems to forget things, that he seems to be a little confused at home. And these may not be large enough to pick up on our usual cognitive assessments. So this is one area that we can research on how it is impacting the quality of life of the patient. So there are subtle chemo-induced cognitive changes, may not necessarily be picked up on evaluation measures, and the usual affected areas are fluency, executive functioning. Now, there are, if we talk about evaluation and outcome measures, there are tools that assess these particular areas, like the Hopkins Verbal Learning Test and the TRAIL test. These do assess these areas or are good enough to pick up these areas. But again, these are areas or can be areas of research in India. Tumor in the brain, deficits to be noted depending upon the area the surgery has been done or upon the irradiated areas. Chemotherapy-induced peripheral neuropathy. Now, some of the chemo medications, especially like the vincristine, can have a neuropathic effect on the patient. So in that case, there is loss of sensory motor functions. And what we could do in terms of therapy is provide orthotic supports. So majorly what I have seen is there is an incidence of foot drop and lower extremity weakness. So foot drop splint could be prescribed, strengthening exercises and sensory re-education could be areas that could be worked on in case of CIPN, peripheral neuropathy. These are orthotic supports. So on the left is the Taylor's brace. So in case of metastasis, to provide support to relieve the pain for the patient, especially spinal metastasis, we prescribe a Taylor's brace. And on the left, we have the foot drop splint and the other AFOs. So these are just pictures of few orthotic supports that could be used. Now, sexual health is again an important area which is presently not being addressed or very minimally addressed in India. The patients feel shy to talk about this particular aspect, as well as we as therapists also may feel a little handicapped to talk about this area. But what I feel could be done is education, provide education material, have group sessions, have individual couple sessions, and ask them what their concerns are. Now, a lot of research says that there are different approaches to training in sexual health. They are educated on the anatomy of the sexual organs and how they work. And also it is important to train the patient. Now, sometimes because of the chemo and because of the treatment, it is not really possible to engage in so they have in an actual sexual intercourse, but they can use the it's important to educate the patient on having other means of affection, like sitting close, physical intimacy. All these are areas that we can educate the patient on to combat the effects of being not being able to have adequate sexual health. Return to work. Now, many of the patients may be, at least in India, many of the patients may be apprehensive about how they can return for work or what load they could take. So we can educate the patient on what energy conservation measures they can have. We can assess their skills and suggest areas that they can work with, their work modification, assistive technology, on how they can use technology to improve their outcome, work outcome. Challenges in an interdisciplinary team. Now, it's been, like I said, it's been 1.5 years. I had a difficult time because this is a government setting, and I was put together with the physiotherapy staff here who have been working for here like more than 10 years. And there hasn't been an OT. There has been an OT who left the job few years back. She was there for 2 to 3 years. But there has been a long gap because of the political play between the two groups, or because one group was more dominating than the other. So I've been the OT after a very long while, which means I have to start from the scratch. So I was put under the physiotherapy services. Which means they were very dominant. And the first 1.5, it's very recently, just last week, that I gained the independence of working on myself. But till then I was under them, which means on every intervention, every patient that I had to see, I had to ask them, can I see this patient? And it was very difficult for me. And now, why I'm saying this, all this is the challenges that I had working in such a setting. And many of us may also have similar challenges, but these are just things or techniques that help me to cope up. So I would just like to go through these points. Understand the setting that I am working in, the wards, the system of work. So if you are in such a place where I was extremely new to oncology rehabilitation. Now I have worked with pediatric rehabilitation, but oncology was very new to me. And being in Tata, I had to prove that I am competent enough to stay with the group. So understanding the setting means understanding the ward system, the system of work, the administration, what kind is the administration, would help us to basically, you understand more about the system and figure out what way in which we should move forward. Talk to people, careful talks, in the sense study people. In a government setting, people are quite self-oriented. So they think about mostly about their self-establishment. So talk to people who really wouldn't talk behind your back or spread stories about you. Talk to genuine people who are interested in work. Now, if we are interested in work, so careful talks, talk to people, establish rapport with people, communicate. So these are important things in which we can get ourselves familiar with the surrounding that we are in. Wait till you understand your team. So sometimes we get so emotionally worried or disturbed that there are chances that we have anger outbursts, or we develop personal grudges over time. But wait till we understand the team, in the sense they also need time to understand us. So behave, or let the decisions that we take be very professional, and let it not go on a personal basis. Let it not irritate or hurt their ego, in the sense, you are doing this, or why are you I would always say use the I statements rather than you are not up to the mark. If we feel something is really lacking in the other team, it's better not to use the you statements, because that would hurt their ego and that would cause them to cause more problems for us. So avoid getting personal with on a personal grudge. Such kind of conversation should be avoided. Let us be very professional in the way we handle things. Focus on what we can do and be sincere to patient progress. So let us identify areas that we can do. For example, when I was in this setting, it was very difficult for me initially in the like I said, I had to wait for 1.5 years to get the independence to carry out my own services. So in the meantime, what I did is I tried to reach out to a lot of seniors when I was really depressed or on how to move ahead. I tried to reach out to a lot of seniors, and there are many who have helped me. And I would especially say thanks to Lindsay ma'am, batch of 85 OT. Who has given me immense amount of support. I've reached out to a lot of others. I've reached out to Rima ma'am. And so reach out to our seniors when we have a platform like Opta available, and with seniors who are so readily willing to help, we can reach out to them for input, for suggestions. And obviously they would be able to guide us with their the amount of experience that they have. So look at what we can do and build ourselves with the foundation. For example, I told that I was new to Onco, so I decided that I looked for opportunities where I could build up or attend courses and classes or certification courses where I could build up my knowledge. So I attended the CLT course. I've done a couple of other courses from Summit Education online. So I looked up online on what is available on how to improve my knowledge in cancer rehabilitation. And let's be sincere to how the patient progresses. Now, even if we get one patient, let's show that we can work on that patient and significantly improve the status of the patient. So whichever patient, even it's just one patient. Now, there are many days I've had nil patient records. So even if it's just one or two patients, be sincere to the patient that we are seeing, and let us focus on what we can do for them. Ask the admin, but wait and keep asking at suitable intervals in a pleasing manner. So if you're not able to get anything, it's like ask and keep asking till you receive. So keep asking the admin, but make sure that we do not irritate them. Identify our goal for work, what exactly we want for the work. Like, for example, in my setting here, what I want, since there hasn't been an OT, I have taken it like a challenge that I want occupational therapy service to get established here. So this is my goal for this setting. Now, I'm not a permanent person here, but as long as I'm here, I would like to make a strong foundation for the next person who's coming after me. Identify my personal goals and the challenges. Note what works. Make a note of whatever works, the little, and people who support. There may be people who are willing to support you, who are willing to give patients to you. There may be consultants who like your work, who appreciate the little things that you do. So identify such people who are willing to support you and communicate to them. And while you're speaking to them, make sure that we do not put down the other team, in the sense speak against the other team, because that creates a negative impression about us also. So just speak in terms of our goals and what we can do. Set and achieve goals slowly. Do not fear for asking or presenting your request. Now, I had this huge challenge of fear. I was so overtaken by the in charge of the physiotherapy services whom I was put under, that I was scared to talk. So, but very recently, because of all the difficulties that I had, I wasn't allowed to see patients on my freedom. So I happened to complain about it. And that's when I got the independence that I needed. Now I'm just speaking openly about such things, but this is just so that it benefits everybody. Do not fear. When you're on the right, present your request and be bold about what you're talking. Be confident about what you're placing before the administration. And definitely the administration, when they see you, your attitude, they know how to judge, and they will eventually give you what you need. If you're sincere, if they feel that they understand that you're sincere, they will give you what you are asking for. Talk and get guidance from seniors. Do not carry the stress home. The Tarian principle, keep doing little by little. Now, this is something that I got from Rima ma'am, which means George Tarian sir usually says that if you have to get something new established in a setting, it works like this. If you're moving a table from one end of the room to the other, if you move it at one go, maybe the people around would really object to it, but if you move it little by little, they would get used to it slowly, and and you are also working on what you want to do. So keep doing things little by little. If you're in an adverse situation, keep the large picture in mind. For example, I got a small space recently, so I keep thinking about the large space. Once you get a small space, nail it or take hold of it, make your arrangements, get equipment slowly, so that once the services develop, you can be given larger areas to work in. Once you have freedom and once you have the large picture in mind, once your patient base increases, you can have more therapists to work with you, and that way the department gets established. So look at it with the large picture in mind. I mean, what will happen 10 years from now? If you want your service to be established there, look at it from that perspective. Once you have freedom, visit the wards, identify the patient needs, talk to consultants, discuss and get referrals. And even if it's one patient, give your best and focus on improving the patient. Focus on personal development. For example, if nothing works, try to do research, publish articles, or attend courses. Like I said, identify what all you can do rather than complaining about what you cannot access. Do not give opportunity for anybody to point out to you. For example, be punctual in your work. So do not give opportunities where they have a complaint against you. Now that can hurt you also emotionally and mentally, but be perfect in what we do. In the sense, in small ways, be punctual for work, and be sincere to be sincere in our documentation. And if any mistakes that come from our side, we can always apologize and rectify, and have the passion for work and rely on the Almighty. Thank you.
Ma'am, thank you so much for such an informative presentation, and also thank you for addressing the challenges that we might face in an interdisciplinary team outside. Thank you so much, ma'am. Now we'll move on to the question and answer sessions. So we have quite a lot of questions, ma'am, for you from the participants. The first question is, kindly elaborate on preventive roles of the PTs in cancer.
Yeah, so preventive roles, this is what I know. So one I mentioned is in the breast cancer. We can have the post-operative breast class where they educate the patient on what are the exercises to prevent shoulder restriction of motion. They give a set of exercises that's common for all the patients. So 4 or 5 exercises which they give, which also to improve the shoulder ROM, and they also educate on lymphedema, on what are the skincare precautions. Now, in lymphedema, there are skincare the patients are educated not to use razors. They're not supposed to have the BP cuff placed on their affected limb. When they travel on airplane journeys, they should have their compressive garments on. Now, there are a whole list of precautions in to focus on lymphedema prevention. So that is one area of prevention that we can work on. So this is just in case of the breast, this is being practiced in our setting. And again, like I said, the prevention measures, we can educate the patient on physical activity. And we can, with case of the head and neck, in case of head and neck trismus, immediately after when they are undergoing the RT, now, like I said, the trismus is exaggerated when they are exposed to the RT. So even before they undergo the RT, the patient is educated on using the jaw stretching device so that the movement of the jaw is not worsened further. The ROM is not worsened further. These are few preventive areas that as physiotherapists, they address in our setting.
Thank you for that answer, ma'am. And ma'am, the next question is, how do you manage the behavioral issues on pediatric population, especially when they go through a lot of pain and getting them to do the therapy?
Yeah. So now most of these children, what they present is with initially during when they are admitted, or when they initially during the initial phase of treatment, the first chemo, they have a lot of behavioral differences, in the sense they may not they may have tantrums thrown, they may be crying episodes, especially the smaller children. But what we usually see is over time, over the course of treatment, that means by the third or fourth cycle of chemo, the children, maybe it's just that they don't express, but they become more competent with the treatment phase. They are more compliant to having the undergoing the treatment process. So the children themselves know that, or maybe they just get accustomed over time. So this is one way that initially it is seen, but over time it reduces. The other thing is we can use a lot of, initially when we educate the child on the treatment course, like I said, pre-rehab aspects, there are many books that are available, small children friendly, child friendly books, which actually show the journey of a cancer child through the treatment phase. So there are many books that are available. They're even available on Amazon. So these books can be used to educate the child, to show the child that this is what he or she is likely to undergo. So he or she will be more receptive to going through the treatment phase. Now, the third thing is we can use many role plays. For example, we can use a doctor play with a lot of equipments like a syringe, or we can use this stethoscope, and have role plays where the child actually tries to take injection for somebody, or tries to examine the chest using the stethoscope. So these kind of play with the hospital equipment helps the child to accept the treatment process and undergo that with more ability. So child play is one thing, role play, these kind of role play techniques. And then again, the next line of management can be symptom based. For example, if they are withdrawn, if they have anger episodes, we can try to use recreation activities, figure out their areas of interest, and use those. For example, with Soham, like the picture that I showed, Soham was very withdrawn, but with that painting activity, he improved a lot. I mean, he coped up a lot better. He was more, he smiled more often. So I'm not saying that it was with that activity alone, but at least such activities of their interest, leisure activities, can help them to adjust to the hospital environment better. Now, the other thing we have in our setting is we have NGOs. So the children, because they have to come frequently for their chemo, they are made to stay in an NGO that is there in the hospital campus itself. So we have the St. Jude Institute, where they give an accommodation. So St. Jude is an NGO which has lot of activities for the children. So they have a tutor for helping the child cope up with the missed on education, the classes that they have. So the academics is definitely compromised. So they have a tutor to help the child. And many of them time, if you talk to children, they would say they're missing their studies. They would have been very good at studies, very good at academics. So they say, I'm missing studies, I'm missing academics. So St. Jude has activities. They have, on special occasions, they have dance programs and other extracurricular activities, which actually helps the child to cope up when they are not in an hospital admission per se. In the hospital, we can have, as OTs, we can introduce recreational activities and group activities which can help the patient better. And again, there are, in the West, they have physical activity sessions, yoga sessions, which help the children to cope up better. So these are some things. They have child life supporters or child life specialists in the West who organize different activities in the hospital for children. So these are various areas or various ways in which we can deal with the psychological impact that the child faces.
Okay, the next question is, in a stem cell transfer, which has more chances of GVHD, autologous or allologous?
Allologous, definitely. Autologous has lesser chances of GVHD.
And in
because it is from because it is allologous definitely has more. Allologous has definitely more chances of GVHD.
Okay, ma'am. The next question is, in case of cervical cancers, how long should we advise to use vaginal dilators?
All throughout their life. In India, women face a lot of difficulty in accepting the use of cervical dilators, but that again, it's important to educate that it needs to be used throughout life.
Okay, ma'am. So going for the next question, how do you handle a situation where the doctor
and again, this applies to lymphedema precautions also. It's a lifetime set of precautions that they have to follow. Yeah, next question.
Okay, ma'am. The next question is, how do you handle a situation where the doctor expects you to mobilize a child under palliative care, but deep down you know that you would do more harm to the child?
Just speak to the consultancy. In this case, we know the child, we know the therapeutic aspects of our work better. So speak to the consultant if you feel that it would harm the child in that way, or again so speak to the consultants on what we feel about the treatment aspect. Speak boldly, because we know best about what we are doing. And again, make sure we are on the right. Find the other the scans, the other reports. Make sure that we are on the right before we speak.
Okay, ma'am. Ma'am, you were actually telling about the advanced courses that they have started, and now you have did it on head and neck. Are there any other advanced courses that will be started in the future, or have they already started anything now, ma'am?
In India, this was the first time. This year was the first time that they had head and neck, but they're also planning to bring in wound management, I suppose. And this advanced course, we would get the clear certification of advanced course only when we complete all aspects. There is wound management, and there are a few other programs also which actually completely constitute the advanced course. So it is in India, they didn't have the time this year, but maybe in future they would bring it if they have required number of days and required minimal number of participants.
Okay, ma'am.
So they usually have it in Bangalore, Bombay. These are the two cities that, and two cities where they've had it in the past. Now this is the 4th year of basic CLT course. These are the two cities where they have organized it. They're also looking at other cities, but they have logistic concerns.
Okay, ma'am. We have one raise hand from Ruplok, sir. Yes, sir. So you can unmute yourself. So can you hear me, sir?
Hi, Blossom.
Hi, sir.
Blossom, I have a few questions. First
Yes,
thing is, you were talking about prostheses being used in a lot of cases, right?
Yeah.
So how
You mean
costly
the
are your
prostheses, sir?
Yeah, the breast prostheses. Then there are prostheses used in upper limb and lower limb cancers also, bone and soft tissue cancers also, right?
Okay. Yes.
So how costly are these prostheses, concerning the number of years of life left is just 5 years maximum right now in India, 5 to 10 years?
So in Tata, we have a prosthesis unit, an orthotic and prosthetic unit that functions in association with Tata. So there is a subsidized rate that they give it at, and the Autobox is actually available. So when there are chances, if the patient has not shown any metastasis post 1 year after receiving the prosthesis training, they're eligible for an Autobox prosthesis, which is again available under the government at a subsidized rate. So government has a lot of policies and measures which actually help the patient to get the processes at a subsidized rate. So it is good enough if they're able to survive, at least even if it's for a short for 5 years. If there are ways in which they can access it. And the breast process is like 5,000. So most of the patients actually go for it.
Okay, so the breast prosthesis, I agree, it is of less cost. Okay, but the lower limb and the upper prosthesis, upper limb prosthesis are quite costly as far as I know.
Yes.
So does your institution still supply them on subsidized rates?
Yes.
Okay.
So like I said, the orthopedic unit that we have, so it's called Borges Home, where they give it at a subsidized rate.
Okay, so that is one question. Coming to the next question is, you were talking about this preventive role. So is this preventive role only post-cancer you're talking about, or is it prior to post? Because you had mentioned it during your slide that it was pre-cancer. So I was wondering, pre-cancer, how do you prevent cancer?
From what I have understood is physical activity actually plays physical activity, nutrition, all those lifestyle. Now, definitely it's a lifestyle condition. So educating on the community. Now, what the preventive aspect I put in is particularly with respect to the treatment. But on general, definitely we can educate the crowd as health professionals. We can educate the crowd on ways in which it can be prevented. Physical activity, lifestyle modifications is definitely one way in which we can address it. Yes.
Okay, and the last question or the last suggestion or whatever you take it as, like how long do you as a physiotherapist and occupational therapist follow up the case? Because what happens is most of these cases, they develop skin problems, they develop skin breakdowns. So do you have some social help groups? Because thing is, it's very difficult for them to get in touch with their operating surgeon or get in touch with, because the surgeons are very rare in India. As far as my knowledge goes, I think there are only 4 or 5 like orthopedic surgeons who are actually operating on, like, I'm not talking about the other conditions. I'm talking about the orthopedic condition, because I have been in touch with this oncology department. So there are only 4 or 5 orthopedic surgeons who do oncology surgeries. So do you have self-help groups in your institution or anywhere where they can still be in touch with that people and they can talk to regarding their conditions? Yeah.
So I'm sorry to say that in our setting, at least in Tata, a government setting, being a government setting, maybe most of the professionals would, it's like completing their job and getting back home. So I haven't seen, I must say that the follow-up is not, it can be improved. There are aspects in which we can improve. So this, where I work, it's an acute setting. So we follow up with the patients when they return to us, when they return for consultation with the consultant, or when they return for their RT follow-up. That's when we ask them to, they have to come to us. We make it compulsory that they have to come to us for a follow-up. That's how we get to meet them. But any other kind of follow-up is definitely not done from our side, and we do not have organizations also that actually do this. But there are some NGOs which do work in the hospital, but I'm yet to be clear about how they really work, whether they do intense follow-up. I'm not really sure about that.
Okay, because most of my like oncology cases or my cases which I worked on in CMC, they are still in touch with me. So I know about few of them who died and few of them still alive. So all of them I have been in touch with. So I am frequently in like connection with them. So that's why I was wondering. So how do you do that? Anyway, thanks. It was nice class. Thanks, Arvinda.
Thank you, sir. Thank you. And I think Sundar sir has a question. That is raise the hand, sir. Hello, sir. Good evening.
Hi. Good evening. Thanks for the wonderful presentation. I think you've covered quite comprehensively. I just wanted to understand your referral mechanism. Do you get to see all the patients they come to the hospital facility, or do you get referred with specific concerns and then you get to see them?
We don't see all the patients, sir. We refer I am still establishing, but we have specific concerns that the doctors know, for example, for trismus management or for vaginal dilation. So these are specific concerns that they send us the patient.
Okay.
But except for the breast DMG, where all the patients are made compulsorily after the post, if they're operated here in Tata, the next day they have to attend the class, and they are made sure that they follow up with the department. So breast is one DMG alone, where all the patients are compulsorily made to follow because they have to compulsorily attend the class. But all other DMGs, it's just on a need basis.
Okay. And how has your experience been with trismus management?
So trismus, I have attended a couple of, but again, it is not, even though we do a lot of jaw stretching exercises, it is not one area which shows a lot of, patient shows a lot of improvement in. There can be still deficits that the patient faces. And with regard to radiation therapy, there are a lot of other difficulties. There may be oral mucositis, there may be osteoradionecrosis, a lot of other difficulties that the patient actually undergoes, which, you know, we need to figure out on how we as rehab professionals can contribute to.
Okay, thank you. Actually, with regard to cancer care, especially in the last maybe 15, 20 years, there's been a very strong development towards supportive care. You know, a lot of roles that we play do come across supportive care. But I agree, trismus is a major challenge. We have not really had major breakthroughs in having significant improvements. So we've tried multiple methods. We looked at evidences, but the evidence base for outcomes in trismus is also very minuscule. But with oral mucositis that you mentioned, I think current clinical practice guidelines recommend prophylactic therapeutic laser, even when patients undergo chemotherapy or radiotherapy, especially for radiotherapy for head and neck. It's good to start with therapeutic low-level laser therapy, especially for the oral mucositis, and it has been shown to be reducing the severity and maybe incidence of oral mucositis. And one more thought in the lines of what you had mentioned is about the role of exercise. The current clinical practice guidelines recommend that exercise should be embedded as part of cancer care, right from diagnosis towards the end of the treatment or even post-treatment. The implication of this is that you did mention about cancer-related fatigue, declining functional abilities. Sarcopenia is again a major problem in people with cancer. Cardiomyopathy is a major side effect of cancer toxicity.
Correct.
So exercise interventions in the form of gentle movement or as delivered as part of lifestyle physical activity, in any case, is shown to negate a lot of side effects.
Correct.
We've actually developed a good clinical care pathway in our facility. The reason I'm speaking about it is like I've been working with people with cancer for about 5-6 years now. So we've sort of developed a clinical care pathway that we see all the patients that get admitted in our wards as a default. So we screen everybody and then we see who will need therapy, who probably will need what kind of a therapy. And then we create a pathway to work on that. And then we've sort of integrated exercise that at every admission, patient gets counseling on exercise, receives exercise as a group intervention, and of course, targeted exercises based on their health status also they receive. In addition to the other supportive therapies like peripheral neuropathy or amputation, as you mentioned, or like fatigue, other aspects, oral mucositis, pain again. We in fact wrote a perspective on Indian Journal of Cancer about a year back. Because like if you look at WHO pain ladder, they do not have any role for supportive therapies. They only look at medications. The current WHO pain ladder, even the palliative care program of a country is heavily planned on pain management. The other factors are not dealt with, and they're all medically driven problems. So TENS has shown to be somewhat beneficial. Of course, the evidence is not very strong, but TENS has been shown to have some amount of a beneficial effect, especially in bone metastasis and other kinds of cancer. So the scope of rehab services within cancer care or like therapeutic services within cancer care is humongous. So we could probably look at the emerging evidence and fine-tune our approaches towards that.
Sure, sir. I will be connecting with you, sir, if you don't mind.
I have, Sundar sir, I have one question, sir.
Yeah.
Sir, you were telling that we can use low-level laser therapy for the management, right, sir? But isn't it a kind of contraindication that they were saying few times back, no, sir? Like when you are diagnosed with cancer, you don't go with that modality at all, is what they usually say. How
I
is
think
that?
the concern is very valid because laser is supposed to be perceived that it modulates your tissue proliferation, even therapeutic ultrasound for that matter, or all the healing modalities that we use, pulse shortwave or laser or ultrasound, they're all shown to play with tissue proliferation, and they should probably be cancerogenic, is what the concern was. But we've looked at the recent evidence and then we have reviewed papers. In fact, this question has actually been addressed in one of the systematic reviews, that does laser increase the chance of cancerous tissues? And current evidence do not support that belief. And in fact, if you look at the MASC, the Multinational Association of Supportive Care in Cancer, they released a series of guidelines in 2019, June, July. It's come as a one or two supplement volumes as evidence-based statements and reviews for multiple management strategies for cancer. Among them, one is on oral mucositis. And oral mucositis actually depends heavily on low-level laser therapy. They've even given parameters. We have been using low-level laser therapy as part of our standard care in our facility, and the results are pretty encouraging. In fact, within our country, Manipal is one center that has pioneered the use of low-level laser therapy. Dr. Arun Maya was the gentleman who has done a lot of work on low-level laser therapy, and his PhD student Ajay Gautam in the year 2010 to 14. In fact, his research papers have actually led to the development of these, or other heavily cited in the current clinical practice guidelines. They use a scanning laser in the facility, and probably it gives a lot more control over the areas that you can cover. That's been found to be quite beneficial.
Okay,
I'll be happy to
that-
share the papers as a link in our in our clinical discussion.
Clinical discussion group, yes, sir. Because because I'm in the teaching sector, we still teach laser as a kind of contraindication. This has actually opened my mind towards this view towards laser.
In fact, I use a lot of therapeutic pulse ultrasound for radiation-induced fibrosis, because like what happens is with radiation, I clearly remember a particular patient who had a parotid gland tumor. She was excised for that. So, and then post-operatively, she had a lot of stiffness, and she was on radiation, and the stiffness was increasing. So we started pulse ultrasound immediately, and then we started mobilizing the scar tissue mobilization. But when we do it when the patient is receiving radiation, is that the risk of skin breakdown is very high. So we should be careful in terms of our clinical skills, and then we should be able to judge the skin reaction to radiation, grade it, and then use it accordingly. There are gradings for radiation dermatitis. So we look at the grading, and then we'll see at what and then we use it. For radiation-induced fibrosis, for trismus, I've used pulse ultrasound to a reasonable extent. And then we combine that with stretching exercises, jaw mobilization. I wouldn't say we've had great results with trismus, but with regard to soft tissue fibrosis, we've had a reasonably good outcomes with those parameters.
Okay. Thank you, sir. Thank you so much, sir.
Sundar sir.
Ruplok, sir. Yes.
Yes, Rupalo.
Sundar sir, since you're talking about trismus and all that, have you used this what do you call that, taping modalities to release fibrosis?
I've not been trained in taping. I've not explored that option. I'm not sure about the pathophysiological mechanism that can be corrected with taping. The way we see, I understand your point about trying it out with taping, because the influence it can have on our fascia and in our tissues.
Yes.
So the logic looks rational, but when you look at the pathophysiology of trismus, it's actually poorly understood, despite being a major functional problem. Why trismus happens and why is it so resistant to treatment is something we probably have not understood. In simple terms, we see in terms of the masseter goes into spasm and then you're not able to open your mouth. If it is as simple as that, we can relieve that with muscle relaxant.
Needling.
Medication should be easily taken care of. But probably that's not the reason it works. So we still don't have much of a clarity of why the trismus is so resistant. So maybe it's a line of approach that can be explored, but I personally do not do taping.
Even your soft tissue fibrosis, which you're talking about, like
Yeah.
with even radiation, it could be taken care with this taping as like
Okay.
my concern. Yeah.
I
thinking about that.
do not. I'm not trained in taping, so I do not use it. But maybe that's an area that can be explored. Yeah.
Yeah, another thing, so you're talking about is exercise for improving the lifestyle of the patient or improving the life of the patient.
Yeah.
So there is one aspect which I saw in most of the patients was like post-cancer, they had reduced appetite and all, or post this thing. So how could we change that? Like, since you're working with cancer, that's what I was asking.
I think it's Blossom's forum. I don't want to take it out from her. I'll be happy for her to pitch in. And then if there's anything to connect, I'll be happy to connect. But just to keep it short, exercise has a lot of beneficial effects, facilitatory effects. Loss of appetite is also one of them. We put people into a structured exercise program and then we encourage them to achieve a step target. You know, with current day mobile application used, step targets are very easy to maintain. So we do a comprehensive assessment at every admission they come in, and then we attach a follow-up sheet wherein we know what are the parameters they're changing on. So at we get to see patients once in every 2 weeks or 3 weeks based on the chemotherapy schedule. So we monitor their weight, we monitor their pain status, we monitor their grip strength, physical activity, 6-minute walk distance, and fatigue questionnaires. And then we combine that with some ECOG functional scale is there. So we have about 7-8 parameters we document serially and then we follow through. And then we combine that with the clinical blood profile. We have a very strong connect with the clinicians. So we understand the clinical status of the patients. Staging may tell one thing, but the clinical situation could be quite different from just the staging information alone. So we always have a detailed review of the clinical blood profile. We look at the hemoglobin parameters, protein loads, protein albumin, and liver functions. So we look at all that and look at the medical stability. And then we see what intensity they can tolerate exercise and how much they can do it. And that's how we are structuring up.
Okay. Thank you, sir.
Thank you, sir. And ma'am, I have one last question from my side, ma'am. So, ma'am, you were talking about the taping, the K-taping and bandaging. So I just wanted to know whether they use K-taping and bandaging together, or it is like done separately, or like which is more like beneficial or efficient?
Definitely bandaging, and so like I said, the complete decongestive therapy is currently the gold standard for lymphedema management, and the complete decongestive therapy consists of skincare precautions, patient education, bandaging, compressive bandaging, together with the MLD. So these are the different components of CDT. Now, taping is not in that, but definitely taping is being used as an adjunct in treatment.
Okay. Yes, ma'am.
Did you mean to say that they use bandaging over the taping? No, right?
No, ma'am. I just want to know whether they apply the taping and over that they just apply the bandaging.
No, they don't do that. I think it's done separately.
Okay, ma'am. Okay, ma'am. Thank you so much, ma'am. And anyone has any more questions before we close the session for today? I think. Thank you so much, ma'am. Thank you so much for this wonderful presentation, and thank you for all the participants for sharing your valuable time and your knowledge to all of us in this 16th webinar that we are conducting as part of Opta family. Thank you so much. We'll close the session.
Good job, Blossom. You're doing a very good job over there. I mean, a pretty good place to be in TMC. I think that's probably the biggest and the most advanced facility for cancer care in our country.
Thank you, ma'am. Thank you so much. Sir, sir, one more question, sir, before closing.
Okay.
Sir, you were talking about the pulse ultrasound. So I just have another doubt. So, like patient might get sometimes the dermatitis. Sometimes they start getting that upper dermal layer getting peeled off sometimes. So is it okay if we're going to give it on the skin? Will that not cause any other issues, sir?
It will. Like when the dermatitis is beyond grade 2, or
Yes,
like even if it's at grade 2, we do not use it. But the skin breakdown, especially when the person is receiving radiotherapy, at that point the skin breakdown will be very fast. So we wouldn't do it at that point in time.
Okay, sir. Okay. Thank you so much, sir. So Lindsay, ma'am.
No, I just want to say thanks. And really, I've seen Blossom from the time she started and all the challenges she went through. So she's done a real commendable job. And I just want to thank her for this wonderful presentation. And I wish her all the best as she continues. And thank you to all the others. It was great listening to all of you. I don't want to take too much time, but just wanted to say this before the presentation closes. Thank you, Blossom.
Thank you.
Okay, we'll close the session now. Thank you so much for joining. We'll catch up in the next webinar soon.